Today I'm joined by Dr. Chris Obwaka, who will be taking us through assisted reproductive technologies, understanding what is ART, what it's all about. Please feel free to ask any questions after his presentation. So that will be our only house rule, to ask the questions after he's done with his presentation. So without taking too much time, allow me to introduce Daktari. He will give us a brief background of who he is and what ART is all about, and then we'll be looking forward to engaging and interacting with you all that have joined this particular call.
Good afternoon, everybody. Thank you so much, Mudhani, for the introduction. Thank you for everybody who's joined the webinar. My name is Dr. Chris Obwaka. I'm a consultant obstetrician gynecologist trained in Kenya and the UK as well. And it's a pleasure to be invited just to have this discussion. It's not really a talk or a lecture, but more of a discussion. So I have a lot of the maybe medical knowledge, medical know-how, but you probably have more of the legal know-how. So I'm looking forward to learning from all of you today. As we said, we can keep the questions to the end, but if you have any burning question on any slide, feel free to just raise your hand and ask the question or put it in the chat box, and we'll address all those as we can. So the topic of the day is ART, Assisted Reproductive Technology. So anything that's not spontaneous conception is considered ART. We'll look at different types of ART. There's so many different types, but probably just mention a few of the most common ones that are available in Kenya. Let me move this. I'm blocking myself. Yeah. So I'm sure everybody has heard of IVF. So IVF stands for in vitro fertilization. Vitro means glass, and fertilization just means combining the egg and the sperm to make a baby. So with IVF, the eggs are fertilized by sperm outside of the body in a lab. And then once the fertilization has happened and the embryo has grown to around day 3, and that embryo is transferred to the uterus and the pregnancy continues as normal. There's other types of ART. So in clients in whom the sperm count is very, very low, and there's a process called ICSI, done in the lab as well. So they take a single sperm and they inject it into the egg, and that fertilizes the egg, and then the transfer is done as usual, and the pregnancy continues as well. And then there's IUI, which is intrauterine insemination. So this is not done in the lab. This is sperm is gotten from the donor, the man, and then the sperm is prepared, and then the sperm with a special cannula, the sperm is injected back into the womb, and then the lady can conceive almost spontaneously, but without the actual physical action of intercourse, if we can put it like that. So with this, it increases the chances of fertilization because you're injecting the sperm at a specific time in the woman's cycle. So during her fertile window, and the sperm is prepared, the sperm is concentrated, and the sperm is injected back into the woman. So it increases the chances of fertilization for her. And then a very dicey topic, if I can call it that, we'll go through it as well. Surrogacy. Surrogacy in Kenya is quite rampant, if I may call it that, for lack of a better word. A lot of patients are conceiving through the use of surrogates. And the problem is it's a very unregulated field. And we'll go through some of the legal and ethical things that are happening in our country at this point. But basically, surrogacy is where a woman carries a pregnancy for another couple. Maybe I can put it simply like that. So this is just the steps of IVF, the in vitro fertilization. So usually starts with the couple going to a fertility specialist, and a consultation is done. So we take a full medical history, we do a full medical examination, we do blood work, we do ultrasounds, and then we give medications, tablets and injections to be able to stimulate the ovaries to produce more eggs than you would normally. And then once the eggs mature, then the eggs are harvested from the ovary. This is done through ultrasound. Ultrasound and a very fine long needle, we're able to get the eggs from the woman's ovary. Then again, the fertilization process is done in the lab. So this is a Petri dish. That's why it's called vitro in glass. So the fertilization is done on day 3 or day 5, or after the fertilization, the embryo is transferred to the woman. And then if it takes, after 2 weeks, we do a pregnancy test. The pregnancy test is normal, then the process thereafter continues like any other pregnant person. So most fertility specialists would work with a woman for the first 12 to 14 weeks. And then after that, they can be transferred to a general gynecologist or general obstetrician who can continue the process of the pregnancy and delivery. So this is just a picture showing the ICSI, which is intracytoplasmic sperm injection. So the cytoplasm basically just the inner part of the ovum. So this round thing is an egg from the woman, and the cytoplasm is the pink part. And then the little thing that looks like a tadpole is the sperm. So one sperm injected directly into the egg for fertilization in cases where the man has very, very low sperm count. And then this is what we're discussing about the IUI, which is intrauterine insemination. I think at the end of this thing, all of you will be like half doctors with all the terms that I'm putting out. So with this, again, the man gives a sample of sperm. So how it's usually done is through masturbation. So the man, either through self-masturbation or mutual masturbation with your partner, the man can produce a sperm. It's put in a sterile container and gotten to the lab, usually within 30, 40 minutes. It's kept at room temperature while you're transferring it from maybe home to the lab. Sometimes the fertility centers have a room where the man can give the sperm sample, and then it's processed in the lab. So this middle, the picture showing, the picture with the orange is basically how the sperm is prepared and concentrated. And then the picture on the end is using the fine cannula, which is this thing that looks like a syringe and a needle. But the blue part, it's not a needle really, it's called a cannula. It's like a plastic tube, like a small straw. And then the sperm is injected back into the womb. And the sperm which has been injected now goes and meets the egg, and fertilization happens in the normal way. And then this is just a picture showing surrogacy. So you have a couple, which is called the intended parents, and then you have a surrogate mom. So there's many different combinations of how this can happen. So it can be the sperm of the man and the egg, and the sperm of the intended parent and the egg of the intended parent. And then IVF is done. So the surrogate is carrying, like genetically, the baby is for the intended parent. The sperm and the egg is from the intended parent. The surrogate basically will just be the vessel that carries the pregnancy and does the delivery. In other situations, you can have the sperm from the man and the egg from the surrogate, or the sperm from the man and the egg from a donor. So there's lots of different combinations, but ultimately it's just, there's a lady here carrying the pregnancy for a couple. And then after delivery, again, we'll go through it in terms of a lot of legal loopholes around it in terms of once she delivers, then how do we get now the intended parents to get their baby, if we can call it that. So this is just a picture of surrogacy. So yeah, lots of recent advancements in artificial reproductive technology. So there's something called genetic screening or pre-implantation genetic testing. So when the egg and the sperm are mixed in the lab, you can take a small sample of the embryo and test it. So you can test it for different things. So you can know the blood group of the embryo or the baby. You can know the gender of the baby as well. And you can know whether the baby is carrying any genetic problems. So there's lots and lots of genetic problems. There are some which go along the line of gender. So there are some genetic problems that only affect men, maybe like hemophilia. And there are some genetic problems that only affect women. So by testing these embryos before you implant them back into the womb of the lady who's going to carry the pregnancy, then you can prevent some of these genetic disorders from happening. However, some people have misused it. Even in Kenya, it does happen. So sex selection does happen. It's not legal, but it does happen. So there are people who would say, I only want a boy. So they go for IVF, and then the genetic testing is done, and only the male embryos are then transferred into the woman to carry. But then it begs the question of what happens to the rest of the embryos that are female. So that sex selection is not ethical, it's not legal, but it does happen. We have some ladies who, for one reason or the other, they want to delay their childbearing years, and they know naturally as you age, your egg count drops, and then stops as you get into menopause. So some people would choose to do what's called egg freezing. Another situation in which egg freezing can be done is, for example, if unfortunately you have been diagnosed with cancer, for example, and you're going to go through chemotherapy, radiotherapy, both of which can destroy your ovaries, your ovarian function, so can destroy your eggs. So you may choose to do egg freezing. And then after you're done with all your treatment and you're in remission, then you can choose to go through IVF to carry your own biological pregnancy. There's other things that are being tried. Some things like uterine transplants have happened. So there are conditions in which some ladies are born without a uterus, for example, or they have had cancer of the uterus or the womb. They have had to have surgery to remove their womb, what's called hysterectomy. There are this innovative procedures such as uterine transplants that are available in developed countries. Hasn't gotten to Kenya yet. Yeah, lots and lots of myths and misconceptions around ART. We live in a very, very religious, very moralistic country, Kenya. And thus a lot of people frown upon ART because they say it's unnatural because, you know, you're getting eggs from somebody else, or you're mixing your egg and your partner's sperm in a lab, you know, the way they used to call them test tube babies, and then transferring it. But there are couples who can't have children through natural conception. And it affects a big, big proportion of people. So for some couples, this is the only way that they can have a child. And I believe, given like the end justifies the means, as long as it's done in a safe way, it's done in a legal way, it's done in an ethical way, then I think it helps a lot of individuals and couples achieve their dream of starting a family. ART is quite expensive. So the average cost usually is around 600 to 800,000 for the initial cycle. And then after that, if the cycle doesn't work, again, the success rate of IVF in Kenya is quite low, usually between 28 and 40%. So only 1 in 3 IVF cycles will result in you taking a baby home. So the cost of ART is quite prohibitive, but some insurances have now started funding it as well. So it's making, and even some, I mean, when it was still NHF, some covers, corporate covers would cover for ART. So it's not only for the wealthy, accessibility and affordability is improving in Kenya, which is a good thing. In the past, there used to be a lot of concern about how many babies to implant. So some, I mean, if you, the higher the order pregnancy, so if you have twins or triplets or quadruplets, the more babies you're carrying at one given time, the higher the risk of the pregnancy, and the higher the risk that it can lead to miscarriages, preterm labor, problems with your pregnancy in terms of high blood pressure, diabetes, and all that stuff. And also increases the risk that the babies might have congenital abnormalities. So nowadays, I think worldwide, most people are moving towards just transferring 1 or 2. So twins are much easier to handle than triplets and quadruplets and that kind of thing. But we have had situations like in India, somebody transferred like 10 embryos. So that leads to lots and lots of problems for both the mother and the pregnancy. Yeah, again, as we said, lots of legal issues, lots of ethical considerations when we're speaking about ART. So in terms of the legal issues, parental rights and responsibilities. So if we talk about surrogates, for example, so what happens with surrogates, I mean, the ones I've interacted with, there are contracts, so agreements between the commissioning parents or the intended parents as they're called, and the surrogate. So they have an agreement that you're going to carry our pregnancy, we're going to support you through it. And then when you deliver the baby, you're going to hand over the baby to the intended parents. So the legal issues that come up there is one in terms of remuneration. So ideally, it's not supposed to be for profit. So what the guidelines say is that you're just supposed to support the basic needs of the surrogate parent. So if it's like paying her rent so that she has somewhere safe to sleep, if you're giving her money for groceries so that she's eating healthily for the pregnancy, paying for her hospital visits, the blood test she needs to do, the ultrasound she needs to do, paying for the delivery and stuff like that. But ideally, you're not supposed to go to somebody and say, Jane, can you carry our pregnancy and I'm going to give you $1 million, Bob. That's not ethical. It's almost like you're purchasing her as a vessel to carry your baby or your pregnancy. Ideally, it's supposed to be what's called altruistic surrogacy. So there are people who just out of the goodness of their heart say, okay, I've had my 2 children, I don't want any more, but I'm still young, I'm still healthy. Why don't I help other couples who can't have children to be able to achieve their dream of starting a family? So those, you may have come across those, or you may have interacted with people, with surrogates and intended parents. So the agreements, there's no blueprint for the agreement. Usually it's in touch with the legal team and the intended parents and the surrogate, and they all sit down together and say, okay, we have agreed on this. How do we put a legal framework to be able to safeguard everybody from it? One thing that has come up now, there are, what can I call them? Surrogacy companies maybe, or surrogacy managers. So whenever we see surrogates come to the clinic, they're always coming, agencies, yes, that's what I can call it. So surrogacy agencies. So they're agencies that now their work is to connect the intended parents with the surrogates. So they have a big group of surrogates, people who are willing to carry a pregnancy for somebody else. And then you have this big group of people who have infertility, who want a child. Now, the only problem that comes with these surrogacy agencies is that they're in between the 2 groups. So what they do, they get money from the intended parents, and then they pay for the needs of the surrogate. So and in those agencies, they really frown upon the surrogate connecting directly with the intended parents. So the problem with that is that it almost brings a form of, it's almost like trafficking, so to speak. So it's like the surrogacy agency owns the surrogates and then sells them off to the intended parents, kind of thing. There's a lot of legal issues with that, but surrogacy agencies are rife in Kenya, and there's it's a gray area, it's a murky world that even us doctors struggle to understand. The other legal issues about donor anonymity. So we had spoken about if, for example, the woman's egg count is too low for her to get pregnant with her own eggs, or the man's sperm count is too low for him to donate his own sperm for the process of IVF, then you can get donor eggs and you can get donor sperm. So with the donors, if I've donated my sperm for somebody else to have a baby, then what rights do I have because biologically that's my child as well. Am I allowed to know who got my sperm, the baby who was born out of my sperm, my biological child? Who are they? Where are they? Am I allowed to have contact with them? So a lot of gray areas with the donor system as well. We already spoke about genetic testing and embryo selection. So embryo selection is unethical if it's used for the purpose of sex selection, but it is ethical if it's used for the purpose of finding out this embryo is healthy, this embryo has genetic problems, so we use only the healthy embryo. Again, access to fertility treatments, we spoke about the high cost of accessing infertility treatments in Kenya. We still have a lot of people going outside of the country, medical tourism, like to India, for example, where the cost is cheaper. And then the other thing under ethical considerations is the use of genetic material. So more and more we are getting this issue of stem cells. So with stem cells are like the basic or the primordial form of cells And stem cells can really grow into any type of cell. So like a stem cell can grow into a skin cell, can grow into a liver cell, can grow into a brain cell. So there are conditions, for example, like sickle cell or people who have bone marrow failure, for example, they can, I'm sure you might have heard of guys going to India for bone marrow transplants. So there's a lot of, again, gray area and controversies around the use of stem cells for treatment. And you can get stem cells from embryos. So from the output of IVF, you can get, of course, an embryo, but you can also get stem cells. So still very unregulated in Kenya. Yeah, so with the surrogates as well, there's a bit of imbalance in power, I would say. So as you know, the person with the money is the person with the power. So with the surrogates, usually what we find is that you'll find the intended parents, because of the cost of IVF, you'll find they're more well-to-do. And then you'll find the surrogates because they're the ones who are maybe looking for money or looking for a way to sustain their basic needs. We'll find that they're more from the underprivileged background. So if you have an imbalance in power, then there's a problem with the informed consent, because are they only doing it just out of the goodness of their heart, or are they doing it because I know for the next 9-10 months, my rent will be paid, my groceries will be covered, these people will pay for all my hospital bills. And in as much as they're not supposed to be compensated over and above the basic needs, it still does happen. So some people would say, the ones I've seen would say, like once she delivers a healthy baby, she's given a lump sum of say 500,000, for example. So for some people, it's a business. You'll find, I would call them career surrogates. So like this year, she's carrying a pregnancy for this couple. Next year, she's carrying another pregnancy for another couple. So year on year, she's just carrying babies for other people because of the financial gain. So the imbalance of power brings that issue of consent. Is it consent out of altruism, or is it consent out of financial gain? Legal protections as well. As we know in Kenya, the law will protect mwenye nguvu. So the person who's more well-off to do has more legal protections. So we find that it's not a uniform protection for all parties in the arrangement. Carrying a pregnancy in and of itself, and carrying the pregnancy and delivery is a very taxing thing. It's a very nerve-wracking thing. Emotionally, both parties go through a lot emotionally, but more so the person who's carrying the pregnancy. There are situations, again, with the gray area from the legal point of view, which I'd be interested to hear from you guys as well. From the legal point of view, we have, in these arrangements, they also put maybe like that 500,000 I mentioned at delivery. If you have a miscarriage, say you get to 14 weeks and then the surrogate loses the pregnancy, then what happens? Then they say that you won't get that 500,000. But this person has exposed themselves to the risks of IVF, the risks of carrying a pregnancy, all the blood tests, the scans, the medications, all that stuff. But then they don't get anything if the pregnancy doesn't go to term and the lady doesn't have a delivery. A healthy baby home. Fair compensation, I don't know if I can call it fair, because how can you put a price on pregnancy? So we say pregnancy is not a disease, but it does come with a lot of things. So we have people who can be pregnant and develop complications and die, for example, or have prolonged hospitalization, or have clots in their lungs, for example, or have paralysis for whatever reason. So there's no way to judge what is fair compensation. And in terms of when you have this imbalance in financial muscle, if I can call it that, then you'll find the underprivileged person who, more of the time, the surrogate is on the underprivileged side, then they'll be willing to accept whatever the intended parents would be offering. Because I don't think 400,000 is, I mean, if I was a lady, I don't think I would accept 400,000 for the risk, knowing all the risks that pregnancy comes with, to accept to carry a pregnancy. I mean, to go through IVF, first of all, and then carry a pregnancy for 9 months, and then go through labor and have a delivery after that, whether the delivery is by vaginal delivery or by CS. And again, a lot of the times now we are seeing that the delivery tends to be by CS, because with cesarean section, it's more predictable. So labor can go anyway. You can labor for 3 days and end up, with a stillbirth, for example, or you can labor and get to fully dilated and still end up in theater. So a lot of the surrogates are opting for a cesarean section delivery, because with CS, then it's predictable. You're not in labor. You come, baby's out in the first 5 minutes. But then cesarean section still remains a very high risk pelvic operation. And you can have lots of complications, both in the immediate term and long term. So how do we put a value to that risk? That's, again, another gray area with it. So there is the ART bill of 2022. It hasn't been passed yet, but it gives, I think, the best resource for doctors and also for the legal profession to try and get some guidance, because that's what's lacking. We don't have enough guidance. A lot of things are not clarified. There's a lot of contention. And how do we go about the ethical and societal complexities of assisted reproduction? So in this bill, it aims to establish a directorate. So the ART directorate is what will license and monitor all the clinics. So at the moment, they are regulated by the Kenya Medical Practitioners and Dentists Council. But we still have, you may have seen it in the news, that there are a lot of centers that are doing funny things with IVF, and some of them have been sued, some of them have been closed down, some have been in the news very recently, being accused of organ harvesting, organ trafficking. So they aim to establish a directorate that will license and monitor all these things, so that safety is improved, ethical considerations are upheld. And then the same directorate will standardize the practices. So even at the moment, the practices are not standardized across the IVF centers in Kenya. So if you have an overall body that now comes up with the protocols and the guidance on how IVF is practiced in Kenya, then people are now, if you're answerable to someone, then you're keeping all your data, you're submitting your data, there's transparency and there's accountability and all that. And that improves with, of course, the ethical stuff as well. Yeah, so the bill as well tries now to bring about informed consent. So for most of the other operations, I would say almost all other obstetrics and gynecology operations, there's like standardized consent forms that everybody uses. So if Dr. Obwaka, Dr. Kamau, Dr. Kinyanjui, all of them want to do a cesarean section, there's a set form that you have to go through. So you go through what the procedure is, how the procedure is done, what are the risks available, associated or possible, what are the alternatives to this operation, and then the patient signs. So it's called informed consent. For IVF and ART, there's no standardization. So with this bill, hopefully, if it does pass, then there'll be standardization across that will improve safety and improve outcomes as well. A big issue around the storage. So gametes are basically just a medical term for sperm and eggs. And then the embryo is the very early pregnancy. So once fertilization happens, then it's called an embryo. So there's lots of centers doing egg freezing, sperm freezing, embryo freezing. So even with IVF, when you go through the process of IVF, you don't just get one embryo. So you might get like 6 healthy embryos and you only transplant 1 or 2. So you have 4 other embryos. So if this first cycle doesn't work, then you have 4 other embryos on ice that can then be used for future cycles. Those future cycles are cheaper, but you pay for, of course, you pay for the IVF, and then you pay for the storage as well. So with the storage, you pay like a monthly fee, it's almost like rent. It's, I think, about maybe 18,000 a month or so. So if you're freezing your eggs, freezing your sperm, or freezing your embryo for future use, then you keep paying that. So the ethical or legal stuff that comes up here is, for example, if I have, if a lady has embryos frozen and then the lady dies, what happens to those embryos? Can they be used by somebody else? Are they discarded? What are the rules governing the discarding of those embryos? How are they discarded? Where are they discarded? And if somebody else uses them, do they get them for free? Do they pay for the embryos? Are we selling embryos? Like, there's a lot of gray areas. And then we spoke about a bit about the donor rights. So if I donate my sperm, am I worried that 10 years later somebody will come and now say, okay, your biological child, you donated your sperm, and I was conceived using your sperm, so I want 50% of your estate, for example. So again, very gray areas, but hopefully the bill will be able to address those. So yeah, surrogacy regulations. The bill also wants to legalize surrogacy. So strictly speaking, since there's no law around it, it's a wild west out there as concerns surrogacy. It is done openly, but we can't really say whether surrogacy is legal or not because we don't have any laws that govern it. So the bill wants to legalize surrogacy under specific conditions. So the main conditions that we use currently is the lady has to be above 25 years old. I don't know how they came up with the 25. Above 25 years old, and she should have already one child. So you can't have somebody below the age of 25 who has no child, who is a surrogate. However, that does happen, because a lot of the surrogates are like university students who need a bit of extra money, and a lot of them will be below 25. A lot of them will have had no children in the past. About parental rights with the surrogates, again, another very gray area. So I think the current teaching or the current practice is the surrogate mom has full parental rights over the pregnancy that she's carrying, even if she's carrying for somebody else, until she hands it over after delivery. And even the handing over after delivery, it's still a process. So when the baby is born, then all babies are registered with the registrar of birth. After about 6 months, then the intended parents have to go through the process of adoption. So this surrogate now has to say, okay, I've carried the pregnancy, I've delivered the baby. However, I would want to give up the baby for adoption. And then now the intended parents go through that whole process of adoption 6 months later. So the lady can't deliver, and then the intended parents because sometimes you get intended parents from overseas. So the lady can't deliver today, and then tomorrow the intended parents take the baby and take the baby to Canada, for example. The only issue there is that the lady is not giving up the rights or is not giving up the baby for adoption until 6 months later. However, that baby doesn't leave the hospital with the surrogate mother. So when the surrogate mother delivers the baby goes home with the intended parents, not the surrogate mother. Again, a legal problem. How is the baby going home with the intended parents, but has not been officially adopted? Gray areas. Maybe you guys will tell me what, from your experience with surrogacy and surrogacy agreements. I still don't understand how that goes. The bill also aims to prohibit commercial surrogacy. So as we spoke about, somebody is just being a surrogate year after year after year, and they're just getting paid. It brings a lot of the unscrupulous kind of agencies that are just almost like human trafficking, recruiting girls from university, for example, and keeping a big chunk of the money in the intended parents and the surrogate mom. So there's a lot of ukora that goes on in the middle there. And yeah, we spoke about a bit about the parental rights as well. We spoke about gender selection as well. That's in the bill, this ART bill of 2022. So we can't do gender selection for sex. We can't do gender selection for social reasons. We can only do it for medical reasons. And the medical reasons include disorders or anomalies that can be passed on based on whether you're a man or a woman. And then equality as well. All children born of IVF or surrogacy have exactly the same rights as any other person conceived spontaneously or naturally. So even rights to, of course, rights to fair treatment, rights to equality, rights to fair share of inheritance and stuff like that. So that's also in the bill. Yeah, I've spoken about equal rights. Ideally, the children should be able to. So when you go for IVF, part of the test we do genetic screening and stuff like that. So you're able, the baby born of IVF should be able to say, to know that my dad was a Kenyan man of 6'2". He was Luo by tribe, and these are the genetic problems he has. But again, in Kenya, we don't have such good documentation because we don't have any laws around it. We don't have an oversight body that regulates and standardizes all that. So again, it's just very, very murky. And then I think this is my last slide, just on challenges and opportunities. So a lot of the public is unaware about, I mean, a lot of people know, maybe I've heard the word IVF, but the intricacies around IVF, around surrogacy, a lot of people don't know about it. So hopefully through forums like this, we're able to raise public awareness about ART, about the bill that's in Parliament, and hopefully that will improve people's understanding of it, and also empower the people who want to go through IVF, especially as a surrogate. Then you know what your rights are, you know what your responsibilities are, and these agencies can take advantage of you. Hopefully the cost of IVF comes down because it's a huge, huge problem. 30% of couples have infertility, and a lot of people don't want to go through the process of adoption, for example, almost because again, it's African thing, like nataka mtoto wangu, I want my own biological child. So hopefully as the costs are able to come down, then it will make it more accessible for people. Stakeholders we brought in under that ART bill. So we have people in government, the policymakers, we have doctors, healthcare providers, we have community stakeholders, so people in the legal field who can all come together. And again, this will enable us to address these gray areas, or as it's written here, legal ambiguities concerning ART, surrogacy, egg freezing, embryo freezing, all that stuff. So I am happy to hear from you on what has been your experience from the legal point of view as pertains to all this stuff. That there's a lot of gray areas for me as well. I open the floor.
All right, thank you so much. Quite an incisive presentation. I will seek that the participants on the call, please, your experience with surrogacy before I speak anything myself. So I open the floor just for the participants first on the call before Muthoni gives her own intake as well. Any person on the call? So as we wait, Dr. I hear a lot of legal issues and the unethical issues as well. So let me just say, for us, our firm, we don't deal with a lot of family law issues, but we've had the pleasure of engaging with the Law Society on this particular issue because, as you said, there are no laws that actually regulate this particular space. But today, for me, I've also learned about the surrogacy agencies, which I think I'm trying to just find out, even from your own experience, best practice. If you were to look at any one jurisdiction worldwide and would say, this is the best practice, what would that be? What is that country that we're looking at and saying, I think they probably have a better framework and we could borrow one or two key things from them?
So I think I would lean on my 3.5 years in the UK, and that I think was a system that worked. it didn't have all these question marks. Like they have laws that have been in place for a long time and everybody follows them. I never saw like anybody was taken advantage of in terms of the surrogacy thing. I never saw 5 embryos being transferred like they do in some countries. And in terms of, yeah, just the legal framework was really good because it's a more, I would say, a more mature country from the medical point of view. So they have like the British Fertility Society has a lot of guidelines on IVF, on other ARTs, on surrogacy, all that stuff. So yeah, I draw from the British Fertility Society.
Okay, and just in addition to having borrowed from the British, because we have a lot of medical tourism in Kenya. Are the Kenyans headed down to Britain, or are we still going to India for purposes of this to happen as well? Because we seem to have a thing for going to India for most of the things that we have a problem with. We can't sort it out here.
So I think the trend is people go to third world countries for medical tourism a lot of the time, unless you can afford it. So even for like a Kenyan can't just wake up and go and get treatment in the UK unless they're very rich, because almost everybody is on the NHS. So it's like their shift SHA. So if you're not a citizen or a resident, then you have to pay a lot of money for private healthcare, like in London, for example. So a lot of people are coming to Kenya. So I've seen Canadians, Britons, Americans as the intended parents coming to Kenya, getting a Kenyan surrogate to carry their pregnancy, and then going with the baby back to their country. So a lot of first world, as we call them, first world countries, people are coming from there to these other countries like India and Kenya, which are not really considered first world countries, because there's, again, those loopholes are a bit more here. So they're able to come here and jump through the hoops and get it cheaper, get it without too many questions, go through the adoption process without too much scrutiny. And again, the other big ethical issue that we didn't mention is that surrogacy and IVF is not only for heterosexual couples. So we also have, of course, under the radar, but we have same-sex couples or single people who go through this process of IVF, surrogacy, and have a child. We know, according to the law, same-sex relationships in Kenya are not legal, and ideally as well, a single person. So say me as Chris, I want a child, but I don't want a wife. Ideally, I'm not supposed to be able to access surrogacy, but it does happen. So what we have seen for medical tourism, people usually come from outside to us. It's cheaper, it's easier, less questions asked. Less people would go from Kenya to the UK for IVF.
That is so interesting. I'm still waiting for the participants for their call, but I'll keep pushing this question. It's interesting that not only is it opening a legal loophole in terms of ARTs, but it's also opening now the legal loopholes in terms of same-sex couples. So the legal problems keep compounding and compounding as we go along. Rather, it would have been easier to probably legalize the ART bill 2022. So it's such an interesting dynamic that things getting murkier and murkier, and the Wild West keeps getting murkier. As I said, and I really want to say that I haven't been completely following the bill. How do we completely give our own public participation in terms of the bill to help it push as the legal practitioners on this call? Do you know where it's at, the stages where the bill is at, other than Parliament? Was there any call for public participation?
I'm not sure. Actually, I think you guys would be a better place to tell me.
I'm waiting for the rest of my colleagues on this call. I must say that for me, I do not know, but perhaps we can really chime in terms of that. So one of the things that we realized when we've done webinars in terms of female, let me call them issues. The last time we had the webinar on cervical cancer, and just like ART, where not so many people are embracing it, just like even screening for cancer, not so many people are embracing it. There seems to be some African myth or something about just getting medical help. It's the same thing with, I hear from what you're saying in terms of ART as well. Other than capacity building, how do we make this more, can I say, more malleable to acceptance in terms of just giving birth to a child as opposed to, following the older traditional roots of man-woman intercourse baby?
Yeah, I think a lot of exposure brings about acceptance. So I guess, for example, if this bill goes through, then it's publicized and it's in law and it's there. Then more people can be aware about it. And then with it being a law that there's like proper frameworks around it, then a lot of these gray areas, murkiness, shadowiness also can be removed from it. Because with the shadowiness as well comes mistrust. So like somebody says, okay, this person, they're in a same-sex relationship, but I heard they got a child via surrogacy. If that's outlawed, for example, then people, I guess it becomes more acceptable the more people have information about it. So I think the bill would go a long way, and then the government pushing for that directorate which oversees everything. And then the directorate can also now give statistics and figures and let people know that these are the places you can go to have it done safely and ethically. And these are the intended outcomes. Because a lot of the time, even with the cost of IVF, so say 800K, and people are, because it's not regulated, everybody comes up with their own success rate. So like globally, even in the UK, the success rate is like maybe 28%. But you have places in Kenya now, in Nairobi now, who are publicizing 80% success rate, 60% success rate. And you see that false advertising, then basically it's unscrupulous. You're taking advantage of people's lack of information. So we have a lot of these IVF centers that are very dodgy, for lack of a better word. Yeah.
All right, thank you. Anyone with a question?
Oh, yes, I have a question.
Thank you.
Mine is about the issue of surrogacy, especially from the perspective of the surrogate mother. I think this, I don't know whether it's I would call it a moral question, considering that this is someone who has carried a child for 9 months, and there's the aspect of attachment. It's normal for mothers to get attached to the baby they are carrying in their womb. So even from mother to child, I believe biologically there's a connection that the two establish. So how do you handle that for the surrogate mother? Because it takes I think I would call it an emotional turmoil on them, having to disconnect with this child. And I also believe there's an extent to which the child had also developed an emotional, I would think so, attachment to the surrogate mother while they are still in the womb. So how, from a medical perspective, how do you handle such issues?
Yeah, so I mean, the emotional and psychological attachment starts from conception. So, the excitement that comes with, oh, I've missed my period, I've done a pregnancy test. And then, so for the surrogate, she has gone for IVF, the pregnancy test is positive. And then now she starts that journey of the clinics, member clinic, unafanya your blood test. You do scans, you're seeing the baby on the monitor, you're seeing the baby growing. And at 18 weeks, 20 weeks, the baby starts moving. So you can actually, like, there's a living, breathing thing inside your tummy. And then as the pregnancy grows, now that you get that anxiety, excitement that comes with delivery. And then at the time of delivery, you've gone through the whole of labor, you've sweated, you've been in pain, you've pushed. And then what happens, like in Kenya, the surrogate doesn't see the baby. So there's like almost like immediate separation. So in the delivery room, if it's a CS or it's a vaginal delivery, the surrogate doesn't see the baby. The surrogate is not supposed to breastfeed the baby. The surrogate is not supposed to hold and bond with the baby. So that, like, it's a huge thing. Imagine, like, you've carried a whole 9 months and then you deliver and you can't even see the baby that you've nurtured all this 9-10 months. So a lot of surrogates have a lot of mental health issues as well afterwards. Some of them go into depression, some of them get anxiety. So again, the mismatch of they're just doing it. Some of them are just doing it for the money. But even if you're doing it for the money, I don't think you can, as a human being, separate yourself from the fact that you've grown a human being from 2 cells to a living, breathing thing. So I think in the long run, a lot of them will have a lot of mental health issues around this. Yeah, I don't know how to. There's no way to guard around it, because on the other hand, if we want to say, okay, she has carried this pregnancy, let her bond with the baby, I think it just makes things harder. So for example, if she starts breastfeeding somebody, why don't you call it somebody else's baby? She's breastfeeding the intended parent's child that she has carried. She's bonding, she's changing the baby, she's taking the baby for clinic visits, vaccines. I think it just makes it much harder. And that's why a lot of hospitals in Nairobi would separate the baby at birth. So again, nobody has the answers to that, really.
I think in light of the same question, somebody is asking, what are the negative effects of or risks associated with ARTs? And I know we really dealt in terms of surrogacy, but I do believe if we touch on the other 3, IVF, for instance, IUI as well, are there any negative risks that come along with these procedures as well?
Over and above the risk to your pocket, of course, there's health risks associated with it. So for the process of IVF, because it's not a natural process, we have to basically take control of your cycle, give you medications to ovulate more than you would ovulate naturally. And then you have to have a procedure where a needle is inserted through your vagina into your ovary to harvest the eggs. So the medication comes with its own side effects, own risks. We have people even admitted because their ovary has been hyperstimulated and now their ovary is huge, giving them lots of pain, fever, bleeding into the tummy. And then the complications of actually harvesting the egg itself from the ovary. So it's a surgical procedure. So it comes with its own surgical risks of bleeding, infection, injury to your bowel, injury to your bladder. So there's all those health risks. And then the pregnancies conceived via IVF are also at increased risk of pregnancy complications. So miscarriages are higher, preeclampsia, which is high blood pressure in pregnancy, is higher. Preterm labor, so going into labor very early, is much higher, ending up with a cesarean section. So there's all these physical complications that you can have. And then we've also touched on the emotional and psychological complications that you can have from IVF, for example. Yeah, so it's lots of things.
And when we look at the issue about ethical issues in terms of it must be altruistic, and it should not be about profit, I think if we are honest with ourselves, Daktari, there must be some level of compensation, because compensation here cannot look like I've catered for your medical costs, I've probably paid your rent, or I've done all manner of things. There must be some, when we sign a contract, there is the offer and the consideration. So what's my consideration as the mother who has carried this person for the last 9 to 10 months? Rather than saying it's an ethical stroke moral issue, there must be some compensation for all the negativity that you have highlighted. How do I get that? And yet we want to put that in a bill and say no profit, just related costs. It's like asking you, let's pay the fare and transport and not the actual doctor fee. No.
Yeah. So the two things with that. One is, how do you determine the cost of pregnancy? How do you determine the cost of the risks that you have to go through? How much is your womb worth? So we can't really put a figure on that, because maybe Mudoni will say my womb is worth 2 M, and then Christine will say my womb is worth 5 million. Like, how do you can't value somebody's body part. The other thing is, if you bring up the issue of compensation, then also opens it up to unscrupulousness, so like an element of trafficking. or almost like organ donation, like I'm donating my uterus to you to use, and then I give you the baby that my uterus has grown. And that's why even in the organ donation world, you can't sell organs. Like you can't sell kidneys, livers, and stuff. Like it has to be altruistic donation. So it can be somebody maybe who has signed up as an organ donor. If they're in an accident, then their liver and heart are donated to needy people. Because then now you have, with the organ side, is now you've heard all these stories of people are being kidnapped and being found without organs. That's all because of the black market trade in organs all around the world. And the same with surrogacy. So now you have these agencies that are the keepers, or they own the surrogates, and they're selling the surrogates off to intended parents to carry their pregnancies. So if you remove this issue of compensation, then it becomes purely altruistic. Like Rosafi to me, I want to carry a pregnancy for somebody. I don't expect any pay over and above the normal basic sustenance and medical costs. And that will remove a lot of that room for it to be misused, I think. So that's my take on compensation.
Okay. I think even another participant is asking, surrogacy being a contract, what are some of the remedies for both parties in case the contract is broken or something? That's why I say it's a contract. So a contract must come with something, and then there are repercussions for breach. What are my rights? What are my obligations just to carry the baby, pay my... Then if that does not happen, then what happens after that?
Yeah, so that's the importance of having like a very detailed contract to start with, so that there's no gray area. So all outcomes are catered for in the contract. But we do have, the law says that the surrogate is the mother until the point where she gives up the baby for adoption and the adoption process is done. So at any point, even as it is in Kenya, at any point the surrogate can say, I've carried this pregnancy for 8 months, may have bonded with this baby, I'm not giving you. And there's nothing that the intended parents can do. And even if you have a legal contract, since there's no laws regulating it, no strict parameters that we are working with, the surrogate mother is well within her rights to refuse to hand over the child to the intended parents. Even if you've paid for all her visits, you've paid for delivery, all those things, it doesn't matter. As long as she carried the pregnancy, she is the mother until she hands over for adoption. So until this bill goes through, we are still just in those fights. But there's no way you can take, you can't sue the surrogate mother for refusing to hand over the baby until the adoption process is complete.
It sounds like what we call a contract that is it's called void ab initio. It's non-existent, it's a nullity. So yes, you're basically just trying. If the surrogate agrees, well and good. If the surrogate doesn't agree, well and good as well. So very dicey. I would say that we really need to clamor for the push of the bill to actually have some form of legislation ongoing. Because as you said, it's the wild, wild west. Anything goes. Anything goes. Actually just goes. So that's a contract, what we call void. From the word go, it's just a void contract, but you're pretending you're in a contract.
And can you have a contract based on no laws? Like how, okay, like now the ART bill hasn't been passed, so there's no laws in Kenya governing, say, surrogacy. So when you guys are doing the contracts, what are you basing it on? Or it's just like common agreement, mutual agreement?
So the beauty is that there's a legal, we call it a legal lacuna. There is a gap. So it's not been deemed illegal, neither has it been deemed legal. So you see there's a gap in between, because nobody has come out from the medical body to say this is an illegal activity. It's not illegal, so nobody has deemed it. So what we have a legal vacuum in between, such that you can play around it as you deem fit. So yes, you have a contract, but I think to an extent of enforcing the contract completely, then it also now opens up other laws like children laws, the actual constitution, like what you're saying about people taking, choosing whether it's a boy or a girl, that's discrimination under the constitution, you know? So now it will start opening up another bottle of other laws where we'll be finding, we're interpreting the law, trying to pin now other things on it, because there's no bespoke law that just talks about ART contracts.
Yeah.
So you will have a contract, yes. If you're lucky enough, the contract will go through. But if somebody appeals the implications based on other existing legislation, you might find a way to invalidate the entire contract.
Yeah. And I mean, it brings up that thing of, I mean, I've seen it maybe once or twice where the surrogate mother holds the baby hostage and says, okay, we had agreed on 500K, but me, I want 2M. If you want this baby, you want to go with this baby to Canada, what do you do? You can't enforce that. You can't, you just, it's murky.
You really can't. So it's what you said, it's the wild, wild west. So this bill really needs to go through to provide some parameters to work around, you know, so that at least even when we're talking about rights and obligations, we know who has what right, who has what obligation, all the way down. Yeah. So I cannot see any other question, but this has really been interesting. Clearly, Daktari, I don't know how you're doing it. Tutakuta kufunga hizo agencies zote. People who are making a kill out of all of this. But thank you so much, the participants on the call. Thank you so much for staying on until to the very end. We do hope that we can have a further conversation on this. I think Daktari will invite you again. Please do accept our invitation, and then we'll probably get more deeper into the legal issues that are actually facing that particular spectrum, and what else we can lead on in terms of the already existing legislation, so that it can give it so something to hold on to. So if we do invite you again, please do honor our invite. Thank you so much for taking us through the presentation. I do hope and believe that everybody has taken something home with them. So thank you so much. Do have yourselves a good afternoon.
Thank you. Have a nice day.
Thank you so much.